Mike Gibson, Bobby A, talking about the agent trial. Bobby, this is just amazing news. I've been waiting to see some data here from the US. Talk to us about the trial.
Thanks, Mike. The Agent IDE trial was really the first randomized trial conducted in the US to evaluate a drug-coated balloon for the indication of coronary in-stent restenosis. We completed that trial last year, and just recently at CRT, I presented the full final results, 600-patient trial, and the results were markedly positive for the agent balloon compared to conventional balloon angioplasty for patients with coronary ISR. So really, we're pleased to report that, and the paper was published simultaneously in JAMA. Good news for our communities.
Great news. I mean, tell us some of the highlights of the findings.
Well, the trial was a 2-to-1 randomization. So patients with coronary ISR of a de novo vessel and they could have multiple layers actually of stents. In fact, 40% of the patients in the Agent IDE trial had multiple previous layers of stent. They were randomized in a 2-to-1 fashion to receive angioplasty and treatment with a drug-coated balloon, a paclitaxel drug-coated balloon, versus plain old balloon angioplasty. The primary endpoint was 1-year target lesion failure, which is the composite of ischemia of cardiac death, ischemia-driven target lesion revascularization, or target vessel myocardial infarction. The very high-risk population enrolled, as I said, 40% multiple stent layers, 50% diabetics, 50% primary myocardial infarctions, 75% multivessel disease. So maybe one of the highest risk restenosis populations we've ever studied. And the 1-year results for the primary endpoint were markedly positive, and greater than 10% absolute risk reduction for the primary endpoint. And if you look at the components, 50% reductions in TLR and 50% reductions in target vessel myocardial infarction. So hard endpoints that matter to patients.
Wow.
Percent reduction.
Wow.
First time we've seen something like that. 6 stent thromboses, all 6 of them happened in the conventional balloon angioplasty arm. So I would say a resoundingly positive study that subsequently led to device approval. That happened just this month. Earlier this month, 4 weeks ago, the FDA approved for the first time a drug-coated balloon for coronary indication.
Amazing. Talk to us a little bit about the technology. I used to play around with these things, dipping balloons in lytics, and believe it or not, it gets absorbed onto the surface and then gets into the wall of the vessel. Talk to us about the delivery of all this and, the mechanical and engineering, things that go into this.
Yeah, it's really an engineering and sort of biochemical feat here to be able to do this. We're so used to drug-eluting stents. Of course, in a stent, you got something that's going to sit there for the rest of the patient's life and has drug embedded in a polymer. It's slowly going to be able to weep in and be absorbed by the tissue. Here, you've got just on the order of seconds to minutes to deliver drug and have it stay there, have it get transferred off the balloon. It's got to navigate through the vessel and not fall off and get absorbed into the bloodstream. It's got to be transferred in a 30-second, 1 minute, some people go a little longer, inflation. And then it's got to stick in the tissue after you pull the device out and then do its thing, prevent restenosis. And part of the reason that can be accomplished, that's actually a very different set of qualities that a drug needs and an excipient, the stuff that the drug comes in, needs compared to a drug-eluting stent. And so, some people ask me, why did we see different? We're seeing different drugs. Are we going to paclitaxel again? I thought that wasn't great on stents. It turns out that the things that make it not great on stents make it potentially particularly good for a balloon. So what are some of those things? It's hydrophobic. So it repels water. You put it in blood, it doesn't dissolve. So it's going to get to the vessel. It is lipophilic. It finds tissue and membranes, and it wants to embed itself and stay there. This particular drug has a crystalline structure that is sticky. If you look at it under an electron micrograph, it has sort of shards of, it looks like shards of glass, gets in there and it stays in there. And so when the balloon inflates and you take it out, it stays there. It enables a very low dose of paclitaxel to be put on it with very little kind of particulates downstream that's been in the preclinical testing. So all of these we think have contributed to these resounding positive clinical results in the trial.
Just amazing. You know, when we used to do a lot of intracoronary drug trials, we had balloons that would actually not passively, but actively push the drug out. But this is just kind of a passive delivery. Is that right?
Yeah, that's right. That's right. It's the balloon is up and it's on the coating, it's coated on top of the balloon and then it's sticking there. It's got a preference for staying on the vessel wall rather than pouring downstream. The balloon deflates and it stays there. Yeah, we're not sort of pressurizing it like something like the Clearway
Right. That's
catheter.
what we had used in some of
Yeah.
like Fuse AMI trial. We were pushing
Yeah.
the side. So
Yeah, and and you think about that design, that was not a drug that needed to stick around for the long term. That wasn't, your intent when you designed that trial. It was an acute therapy for, thrombus and ST like cardiac infarction. This is different. This is really less about the mechanics of getting a drug there, but the properties of the drug itself, which really, and the excipient, which make it such that it'll stick around for a while and do its thing.
this is just so cool in terms of the engineering, just amazing.
Yeah, it really is.
So, Bobby, where do you see this being used? Obviously, this was in-stent restenosis, but what about, de novo type A lesion, I mean, in a small vessel? I mean, where
Yeah.
do you see this expanding out into other areas in the US?
Yeah, it's definitely going to be evaluated, I think, in those different settings. For right now, we won't have necessarily a label for something like that. The approval is going to be for in-stent restenosis, but I'm really interested in these other settings for sure. In Asia, in Europe, if you listen to any Antonio Colombo talk in the past year, I mean, they are really thinking about interesting places to apply drug-coated balloons and de novo lesions, bifurcations, osteal circumflex, where we know is notorious for failing when we put stents in there. So I think it's a really exciting possibilities. Long lesions, small vessels, as you're saying. As a CTO, interventionalist, I do a lot of kind of gentle balloon angioplasty to get vessels with better outflow at the end of CTO procedures, and that might be a place where we're interested in doing it. The data has to follow. We need to see the evidence to do it, but I think that's certainly going to be a lot of enthusiasm.
If you were, born suddenly, if you had done PCI in the late 80s, 90s like me, and then went away for like, I don't know, 30 years and came back, and now you heard, well, we don't use stents anymore. Now we do balloon angioplasty. Or, it's actually a good thing to dissect the artery and re-enter the artery. It's like everything that we learned or to undo, we're now, doing again. It's like an old tie that, was wide is coming back or something. But it's just amazing to see, it's just always fun to see all the new innovations in our field. So
yeah, I think Dwayne Pinto, our friend and colleague, said, "Oh, this is like Back to the Future and back again." I mean,
exactly.
history repeats itself, but
Yeah.
these are new innovations. But sometimes, we learn things from history, and I think
Yeah,
going
making
back to it.
our old
Yeah.
tools better. Yeah, it's
Yeah.
just amazing. Bobby, thanks for joining us. It's an amazing update. And thanks to all of you for joining us here for this update from Bobby on his amazing trial, the agent trial. Thanks, Bobby.
Thanks, Mike.